Hey everybody, it's Curtis again. Chapter 9, Patient Assessment, Emergency Medical Responder, our EMR class. Patient assessment, and getting into that kind of the nitty-gritty of what being an EMR is. That is one of the best skills that you can have as an EMR, is the ability to do a good patient assessment. So let's go ahead and get into it. So first, typically going to be the first trained EMS providers at many many emergency scenes. So EMRs can be everyone from just, Chris the citizen to the police officer to obviously a fire service. Some ambulance services even, they're really shorthand and they may have an EMR, and just people that just roll up that are just wanting to help. So a lot of times an EMR will be the first one there. Their job really, that what we're going to start talking about, as you can see listed here, is those first steps of finding out what went wrong, finding out what's broken, and then making sure we get that information to the oncoming unit is going to be some of the most important stuff that we can do. So your assessment of the scene and the patient will affect the level of care requested for the patient. If you don't understand, when we start talking about these patients and we say this one is sick versus not sick, remember, when we say sick versus not sick does not mean they don't need to go to the hospital. We're just saying they're probably not going to die on us. They're probably not really broken up and have the potential to die. That's what we're saying by not sick. So remember, when we say sick, critical patient, not sick, stable patient. They still need to go to the hospital. They just don't need to go lights and sirens with a bunch of noise and all that. So what we are saying is, by how the assessment of the scene can affect the level of care requested, is this. You go there and you don't realize that this person's broken, and you don't realize that they're really sick, and you give bad information, and then the ambulance slows down, or maybe they call for a different responding unit or whatever. We have to be able to give good, clear, accurate information. So it's going to be important that you're able to perform a systematic patient assessment. We'll use those words a number of times as that systematic approach, because you need to be able to go from head to toe and do it properly. So what you're going to do is you're going to use that patient assessment to determine whether your patient has a medical condition or if they've sustained injuries from trauma. So trauma versus medical, a little bit different assessments, a little bit different thoughts. But that's one of the things that we're going to do, is kind of determine this stuff. So the patient assessment sequence, it all comes down to these 5 steps. So we're going to do a scene size up. So when we roll up, is the scene safe? Does it look like that it's safe? Is there chemicals? Are there fluids? Are there this? All of that. Are we in the middle of the highway? Perform a primary assessment. That's those A, B's, and C's. We're looking for those kind of life-saving interventions. Is there something we could do, just like we just learned last chapter about messing with the airway? That's a life-saving intervention. Maybe they need help breathing. That's a life-saving intervention. So we're going to do that primary assessment. Then we're going to obtain their medical history in the event we can. If they're responsive and answering questions and all that, we're going to find out what happened. We're going to find out how does it relate to their past, all of that. We're going to perform a secondary assessment. And what I mean by their past is, if they look like maybe they sustained head trauma, do they have head trauma from the past? Because if they've had a stroke, they may have some deficits. So what I'm not saying is that we're going to find out if they have gout, or if their cousin twice removed has a history of high blood pressure, that kind of stuff. That's not what I'm saying. What I'm saying is what's going on today. Is there a chance it's being affected from their past? So we're going to do that secondary assessment, and then, like every good EMR, we're going to do a reassessment. So we want to make sure that we're seeing, maybe we've done something. Maybe we've performed some type of medical care. We want to see if that helped or not. Are they getting better, or are they getting worse? So some of the skills and knowledge that we're going to talk about, it follows an assessment-based care model, is the kind of the verbiage that the curriculum uses. So what we mean, assessment-based care, treatment rendered is based on their symptoms. So they're not breathing so pretty good, we're going to do something to help them breathe a little bit better. If they're not getting in enough oxygen, enough air, we're going to do something to help them get more oxygen or more air. That type of stuff. So we're going to work on things based upon their symptoms. not based upon what we may or may not think could be going on. So assessment-based care, what that does is it requires you to conduct a careful and thorough evaluation of the patient so you can provide appropriate care. That's what we're there for. Why are we even there if we're not going to provide appropriate care? So this whole thing, it kind of, as you see, it provides a framework so you can kind of start working on all of these things. Provides a framework so you can safely approach the emergency scene, so you can conduct a primary assessment, obtain a patient's history, conduct a secondary assessment, conduct reassessment of the patient. This is what we just talked about a second ago, but this is the patient assessment sequence. Number one, always scene size up. Is it safe? And then we move on down. So scene size up, let's talk about that. It's a general overview of the incident and its surroundings. So where is it located? Are we in the middle of Oklahoma summer? Are we in the middle of an ice storm? So can we be outside for very long is what we're thinking. Is the ground, has a tornado just came through? Are we in the middle of I-40? Or, what's going on? So we need to think about all of that stuff. Overview of the incident and its surroundings. Are we in an industrial setting to where maybe there's more problems that can happen? So, we want to anticipate possible conditions by reviewing and understanding the dispatch information. So we want to make sure that we're getting good dispatch information. The thing that can be hard to not have done on you is to get tricked, though, with some of that dispatch information. Remember, this is like that telephone game. You have someone calling someone to tell them something, and then they tell you that something. So A, we're assuming what the reporter, the RP or the reporting party is saying is correct and accurate. And then B, we're also assuming the dispatch is receiving the information correctly and putting it back out correctly. A lot of room for error there. So don't go in thinking that you're assuming it's this, and then you get there and like, man, I got tricked here. Just understand we're just going on a medical call or whatever it is, and you want to gather as much information as you can, but try not to get tricked. It's not that hard to get tricked. It's actually quite easy because we're counting on dispatch to give us clear and accurate information. So your dispatcher should have obtained the following information: location, the main problem, number of people, and then if there's any safety issues at the scene. So, maybe there's chemicals on the ground, or maybe there's a fire nearby, or whatever. So, there's some other factors, though, that can also affect your actions. The time of day, if it's rush hour traffic and you're in a city, if it's the day of the week, obviously, like if you're, we'll just talk locally. So you're down in Norman or up in Stillwater on a Saturday in the fall, traffic's going to be probably a lot worse. Weather conditions, we just mentioned that, whether you're in the middle of a summer drought or whether maybe you're in the middle of a bad ice storm or anything in between. So with all that, we've got to think about the resources that, could be needed, and then we need to prepare for these situations when you get on scene. So think about what you may be finding and what you're going to do if you do find it. So if you come across a medical emergency, then you want to make sure that if you just come across it, you want to make sure that you contact dispatch. So if you don't have a two-way radio, just use your a cell phone or someone to call for help. But that's if you kind of just come across these things. Scene safety. Park your vehicle so it helps secure the scene and minimizes traffic blockage. Hopefully you'll have some set SOPs for that of how you should park to ensure some scene safety. You want to make sure that you take a look at the scene to ensure you're not putting yourself in danger, and then take a look at and kind of make these determinations that you see listed. So extent of the incident, possible number of people, presence of possible hazards. These are all information that you're going to want to pass on to dispatch. So hazards can be visible or obviously invisible. We may not see gases, but we're certainly going to breathe them in. We may not see a lot of things, or maybe we do see something and it's not a potential hazard, but they can be visible and invisible. So visible, we have some listed here: scene of a crash, fallen electrical wires, traffic, spilled gas, unstable buildings, all of those things that you see listed. Invisible, electricity, hazardous materials, poisonous flames. So, consider your ability to manage these hazards. Now, if you are not trained to manage, electrical wires, then you probably shouldn't be messing with those, because many people have died messing around with those things, and you don't want to be the next one. So if this whole scene is unsafe, you want to make sure that you stay away until whoever it is that's trained in whatever is going on shows up on scene and can stabilize the situation. So make sure you know your exit routes. Make sure that you're able to get out in a hurry if you need to. Make sure you have on your PPE, whatever that means, at where you work and whatever kind of scene you're responding to. Now, we're going to determine MOI or NOI. So mechanism of injury, MOI, or nature of illness, NOI. So basically what we're saying, is it trauma or is it medical? That's kind of what we're asking. So you want to look for clues that can indicate how the accident happened when we start talking about accidents. If you can determine the mechanism of injury or the nature of illness, you can sometimes predict the patient's injury. So sometimes when you see someone got hit from the rear end, and it wasn't a whole lot of damage, to where you're worried about people being broken, you're pretty safe to assume there's probably going to be some neck pain. People are probably going to have maybe a airbag burn or some seatbelt, marks on them and that kind of stuff. I mean, someone gets T-boned, they get hit right into their driver's side door, then there's some patterns that you can expect, some kind of certain injury stuff that you can expect because you've seen this kind of stuff before. So you want to make sure that you're asking people for any additional information, people that know, not just everybody, but bystanders, family members, then the patient, of course. And then we do not want to rule out an injury without conducting a secondary assessment. So if they tell you, no, my neck is fine, you don't just let them go walk off and do their thing, until you want to check it out first. Do your best to get them checked out, make sure that everything feels, everything feels right, and ask them a few questions about whether they were knocked out or if they have any neck or back pain, and those kinds of things. And then standard precautions, of course. So before arriving at the scene, typically most people always have gloves on. Nowadays, we're wearing masks out there. So whatever your SOP is for masks, make sure you're following that. Make sure you always have those things available. You also want to think about, maybe you need more protection. So maybe your service carries gowns or some eye protection or whatever. And you might think about that. If you're messing around with an airway, eye protection is going to be really important. Also, maybe a face shield would be good because stuff gets, spitted and sputtered and all that. So you don't want that anywhere near you. And then when you get done with this, even though you had gloves on, make sure that you wash your hands thoroughly. Make sure you do a good job of taking care of yourself. Determine the number of patients. So if you think you're going to need help, call for help. If it looks like you've got three patients and you can only transport two, or maybe even one of them is critical, you need to get somebody else out there. If you don't have another ambulance service or somebody near you, get a helicopter. You've got to know what your contingency plans are, your mutual aid plans. Make sure that you know what those are. If you're an industrial, maybe you work for an industrial company, then the ambulance service is going to be who you're talking about. And make sure if you do have 3 patients or however many, make sure that you relay that to dispatch, that you have 5 patients that are down, and fill in the blanks. So that way, dispatch has the opportunity to get the right amount of people to the right place. So you want to make sure, like we're talking about, we want to consider those additional resources when we're looking at this. But you may need to put some of these patients into groups. So you may sort them into groups according to the severity of their injuries to determine which patient should be treated, which patient should be transported first. So if you've been on the fire side or EMS side, we're talking about triage. So then if you are on the scene of a big accident, you can say I've got 3 red tags and 2 yellow tags, or however your system does it. But whenever you start considering those additional resources we mentioned, you want to think about traffic control, crowd control. Maybe you need fire there for, some spilled fuel or something. Or we talked about damaged utility lines, and then of course wreckers, and make sure you kind of have an idea about what that whole thing should look like. Now, primary assessment. So the purpose of the primary assessments really is one really big thing, and you already see it right there, and that's to identify life threats to the patient. We want to have an opportunity to correct that. So the purpose of the primary assessment is to identify life threats to our patient. Now, these life threats, they're not just anything. We're going back to our A, B's, and C's. So these are problems with our A, B's, and C's: airway, breathing, circulation. It's important to identify any life-threatening conditions quickly so you can take immediate actions to correct these conditions. These are problems, A, B's, and C's are problems that kill people. Some of these other things that you're going to find, someone's arm going the wrong way, however, how disturbing it might be, typically is not going to kill them. But having something clogged in their airway will, or someone snoring respirations and not moving good air and not having good air exchange, that can kill somebody. So it's very easy to get distracted seeing things going the wrong direction, or maybe a big scalp avulsion where you have this big flap of skin and you can see skull and all of that. But if that's the whole, if everything is encompassed right there, where it's just an avulsion on someone's head, that's not going to kill them. So it's important to stick to this plan, and the plan are A, B's, and C's. So, and we want to be able to have the ability to correct those. So we want to form a general impression. We want to get the sex and approximate age, so whatever, 32-year-old male. Your impressions, it can help you determine whether the patient has experienced trauma or illness. If you see somebody with a bunch of road rash on them and they're on the side of the highway, probably safe to assume that, they were in some trauma. But sometimes the weird thing is sometimes a medical problem can cause trauma. So I've been on a call where someone passed out while they were driving their car, went through a ravine and ran into this field and caught everything on fire, and the car exploded and all that. But everything started because they had low blood volume and they were sick. So sometimes all of this just gets kind of intermingled into one big pot. So the position or the sound he or she is making may help indicate the nature of the problem. So if they're sitting in a really weird position, that can tell us a couple of things. Maybe something's broke. Maybe something is wrong with them neurologically, because typically we don't sit in really weird positions, especially if it's uncomfortable. It's just not something that we do. Now, as you address them, we're going to you see that piece there, determine their level of consciousness. As we look into see what their LOC is, we can gain some stuff too, because when you ask them their name and ask what's going on, and depending upon what they tell you, that can give us an idea, a little bit of insight into what's going on and if they are, alert and oriented or not. And do not let your initial impression block out later information. So don't get so tunnel visioned that it's this, that you're not able to change your mind or have your mind changed for you, because all you can think about is this. It's pretty easy in this industry to get tricked, because people don't read the books, and it's like, well, I read about this and blah blah blah, and people don't read your books, so they do wacky stuff. So talking about the level of responsiveness, so the LOC, right? We want to introduce ourselves and tell them why we're there. We're going to be helping them. Now, if you're on the side of the highway, they know why you're there. They know you're there to help. But this is kind of just how we're just laying this out. Hopefully the introduction, will kind of put them at ease when you go into someone's house and you explain that you're here with the fire service, or you're here with the ambulance, that you're here to help them. We want to make sure that we get their name. We want to introduce yourself. Even if the patient appears to be unconscious, even if they may just be sitting there with their eyes closed, just say, "Hey, Mary, it's Curtis with Shawnee EMS, blah blah blah," and you see if they respond, because that's one of the things we're checking to see what their responsiveness is. Many people who appear to be unconscious can certainly hear your voice, whether they're they are unconscious and they're just they're able to hear things. Not unconscious and hear, but if they're just have their eyes closed, or they're just kind of zoning out or whatever, they can actually hear that. So if they don't respond, then we want to gently touch the patient or shake their shoulder to see if they generate a response. The patient's level of consciousness can range from fully conscious to unconsciousness. So anything in between there. What we have is this, some people just say AVPU, but this AVPU scale. So that's what we're going to be using to describe our patient's LOC, or level of consciousness. So alert, the A, tells you that they're alert and oriented. What that means is they know their name, they know where they are, the correct day of the week, they're alert and oriented. And then verbal, V, verbal. That means the patient's responsive to verbal stimuli. So what we're saying is they react to only sounds. So they have their eyes closed. They didn't notice you walking in, anything until you said something. Then they responded. That's where I was talking about that unconscious but can hear you. And then pain. So response to pain tested by pinching maybe their earlobe or the skin over their collarbone, just trying to get their attention, give them just a little pinch, see if they respond to that. That's going to be pain. And then a patient who withdraws from stimulus is said to be responsive to stimuli. So in the event that you just kind of pinch their skin or give them a little squeeze and they respond to that, that's going to be responsive to painful. And then unresponsive, they don't respond to anything, verbal or painful. Now, rapid exam. Perform a rapid exam. So we're looking for life threats. We've been talking about that. So we're going to perform a rapid exam to identify life threats. So our sequence is AB, unless, remember I told you when we talked about it's always going to be ABCs, except there was a couple of different times that it's going to be something different. And here's the 2 times. So if you are in the middle of a cardiac arrest, or if you have really bad hemorrhaging or bleeding, external bleeding, then we're going to flip it to CAB. Circulation, airway, and breathing instead of airway, breathing, circulation. So we're going to work on getting the circulation going before we work on the airway in those 2 instances. So we're going to assess the airway. If it's alert and able to answer questions without difficulty, we expect the airways open. In an unconscious patient, though, you're going to need to open their airway, whether you use that head tilt or chin lift maneuver or maybe the jaw thrust, just depending upon whether you believe they're a medical patient or a trauma patient. If you think they've sustained possibly some cervical fractures, we're not going to do that head tilt chin lift. We're going to inspect the airway for anything. Remember, we said we're going to look, listen, and feel. So we're going to inspect their airway for foreign bodies or secretions. We're going to clear anything that we see, whether it's with suction or a finger sweep. Remember, no blind finger sweeps. You may need to insert an airway adjunct. If they're not breathing or they have snoring respirations when you get there or something, you may need to go ahead and just insert an airway adjunct. So we're going to carry on with that look, listen, and feel stuff. So assess the breathing. We're going to look for the rate and the quality of their breathing. If they're unconscious, we want to look, listen, and feel, right? So if the patient is having difficulty breathing, or if you hear those unusual sounds, you may see it as another word in maybe further textbooks or in something else that you see adventitious. So if you hear adventitious sounds, same thing as these unusual sounds, but like that weird snoring or maybe some wheezing or like some gurgling in there or whatever. That's what we're talking about, those unusual sounds. So, or those adventitious sounds. Then you want to check for an object in their mouth. If they have an object in their mouth, then you want to make sure that you take it out other than their tongue. Leave their tongue in there. If you cannot detect any movement of the chest and no sounds of air are coming from their nose and mouth, that's pretty simple. Breathing is absent. So they are not breathing. What we're saying is you're looking for movement. We're look, listen, and feeling, right? We're looking for movement. We don't see any movement. We don't hear any sounds of any air coming out. We don't feel anything. We should probably feel a little bit of breath. But we don't notice any of that. They are not breathing. So what we're going to do is we want to take immediate steps to open their airway and then perform rescue breathing. If you were around for the last one, remember my rant about mouth to mouth. That's not what we mean as mouth to mouth. Make sure you have an AMBU bag. Make sure you have a BVM. But if trauma is suspected, you want to make sure that we're protecting their cervical spine by keeping their head in a neutral position. And we want to make sure we're using that jaw thrust maneuver to open the airway. Now we move on. We did our A, we did our B. We're moving on to circulation. Now, if the patient is unconscious, you want to check a carotid pulse. So you'll place your index and middle fingers together and touch the larynx. So you should be able to feel right on there. Remember, in your airway section with where the larynx is, you should be able to feel your carotid pulse over there. So slide your 2 fingers off the larynx towards the patient's ear until you find a slight notch. And then practice this maneuver until you can find it within, 5 seconds, say, of touching the larynx. So, once again, touch the larynx, slide your 2 fingers off toward the ear until you find a slight notch. And right in that notch, you should be able to feel, hopefully, your carotid artery. So if the patient's conscious, Then we're going to assess the radial pulse. We're talking about down on the wrist now. So you want to get your index and middle fingers on the patient's wrist at the thumb side, and then check for any external bleeding also while you're checking for that radial pulse. If you do discover some severe bleeding, you need to make sure that you take action by applying direct pressure. Maybe that means that this depends upon what's going on at that time. You should have a gloved hand. So maybe that means just putting your gloved hand over something for a second to apply pressure until your partner gets you the kit with 4x4s in it. You know, maybe they have a sucking chest wound and they have an open chest wound that's where air is coming in and out. The easiest way is just to put your gloved hand over it to seal that cavity. And then quickly get 4x4s or pressure dressing or whatever it is that you need to do and whatever you're provided with. Now here's what we see. This gentleman was unconscious, so he's checking his pulse. He found his larynx, then he scooted over a little bit and found that notch, and then the radial pulse also. And we're going to move on, perform that rapid exam. So one of the next things we want to do is skin color and temperature. So when we talk about skin color, we're talking about a couple of different things. What we're really doing is we're talking about perfusion. We're talking about how the heart's beating, how much oxygen is in the blood that the heart is pumping. There's a lot of things going on with when we assess skin color and temperature. So pale, white, or light color. And what that tells us is that it's indicating that there's some decreased circulation to that part of the body, or maybe if it's with its systemic meaning, actually, then maybe the whole body has some decreased circulation. And then the next one would be flushed. You see that it's red in color, so that indicates excess circulation to that part of the body. That's why it's flushed. Blue, also called cyanosis, indicating a lack of oxygen, also has some possible airway problems. So that's, obviously when you see somebody that has a blue tint to them, that's not good. And then yellow, also called jaundice, indicating some liver problems, and then there's normal. So that's what we're talking about when we talk about skin color. And we want to make sure that we're also feeling for their temperature. So many times when you feel someone, they might be flushed, they might be a little bit warm, maybe they have some kind of weird infection or something. Typically when someone has that blue tint, they're hypoxic and they're a little bit cool because the body is shunting blood away from the skin, the surface of the skin. So, you want to make sure that you're reporting the temperature and the, what did we say? I'm sorry. The skin color and temperature. Sorry, we get so many words here and then I forget one. So we want to make sure one of the really big deals is this, to update the responding units. That's one of the best things that you can do is give a good patient report to the responding unit so the ambulance coming in knows what's going on. If you get sold the bad bill of goods that dispatch might have given you, then it's not good for our patient. Remember, we're all patient advocates. So sometimes there can be a little bit of, not animosity, but a little bit of stress between maybe, the first responding agency and the next people coming on scene because they feel like they screwed them over and they didn't tell us about this and blah, blah, blah. We're all there to work together as a team. So you do a good job and you know that you did your best job, and then you just turn that over to the next guy and hope that they're doing their best job. So when we talk about updating, what does that mean? We're talking about updating them about the condition of the patient, that responding unit. So we want to talk age and sex of the patient, chief complaint, level of responsiveness. Remember, they were alert, verbal, painful, unresponsive. Their status of their ABC. So airway, breathing, circulation. Maybe you put in a nasal airway. Maybe you're bagging them. Maybe you had to occlude some arterial bleeding, that type of stuff. So try to perform all 4 steps of the primary assessment quickly as you make contact with the patient. All right, let's take a quick break. Actually, I'm just going to make a new one. We're halfway through, so I'm going to shut this one down and we'll start the next one.